All right. Good morning to you all. First of all, extremely sorry for this 30 minutes delay because I planned everything, but at the last moment, I had to attend an emergency. All right. So, extremely sorry for that. Can all of you hear me? Can you all hear me? Right. Okay. Right. So, actually, this class was arranged with a short notice, and thank you for joining. And for myself also, I couldn't arrange the stuff, the technical aspect and everything in a perfect way. I'm really sorry about the quality of the videos, but doesn't matter because you have within a short period you will have your exam in next week. Are you all ready now, guys? Right. So let me introduce myself. I'm Dr. Wasantha De Silva, VOG. Currently, I'm working in Walasmula Base Hospital. Right. And I'm a Erpm teacher. So today we are going to discuss a very important, a recent past paper. And I think this will help you all to, get on with your exam the near future. Okay. So this is just to, give you a rough idea how the exam is like, what kind of questions you will get and how to tackle with these questions and how to get the adequate marks at the end of the day. Okay. So if you all have any problems at any point, you can disturb me and you can ask questions. All right. So I'll be doing little fast because I hope by now you guys have done your theory and you have revised your theory several times. And so I think you all are now confident people to face the exam. You are now so excited to face the exam, isn't it? Okay, rather spending more time on this, right? We will get on to the topic. Okay, so we will start with the MCQs and go on, right? I hope some of you had some time to go through this paper before you attend to this class. So that will be important. And one kind request, can you all please switch on your cameras and focus on your lovely faces? It doesn't matter whether you don't have these lipsticks and the rose powder and all, but just I want to be live, Right, thank you so much. Okay. Okay, Daruni, shall we start with MCQs? Okay, are you all ready? Right. I'll be doing a little faster, but if you all have any doubt, anything, you can clarify and get it clarified. So first one, as usual, most of when you start with the MCQs, usually the first question or the second question most likely will be coming from the physiological changes, antenatal care, that kind of basic topics. Okay, right. So as usual, this is from physiological changes in pregnancy. Increase, this is regarding the respiratory system. What are the changes happen in the respiratory system? Okay. So to answer this question, you need to have a sound knowledge, at least some rough knowledge about this respiratory graph, spirogram. Okay. So this is how it changes. Now, when you take, okay, that's fine, Chattar, no problem. Right. So now when you take breaths in and out, when you are relaxed, calm and relaxed like now, right? You'll be breathing like, without any effort. You'll be taking some air in and you'll be sending out. So this is called tidal volume. Tidal volume means the amount of air that you can take in or going out with your quite normal breathing. Okay, Anjana, nice to see you after a long time. Right. So this is that. What is inspired reserve volume? Inspired reserve volume means after the tidal volume, with your maximum effort, the amount of air that you can take in, like this. You breathe like this. This is the tidal volume. And after that, you do like that. The maximum amount that you can take in is called inspired reserve volume. The same way, after the quiet breathing, the maximum amount that you can expel, like this. Like that, with the maximum effort, right? This is called expired reserve volume. Everything together, tidal volume, inspired reserve volume, expired reserve volume, everything together, it's called what? Vital capacity. Vital capacity. You have to have this knowledge with you now, right? What is residual volume? Residual volume means that when after a maximum expiration, the amount of air remaining in your lungs. That means even with your greatest effort, you can't empty your lungs completely. There will be some amount of air will be trapped inside the lungs, even after deep expiration. This is called residual volume. Okay, right. Clear? Okay, shall we answer to this question now? Physiological changes in pregnancy include increased residual volume. What will happen to the residual volume in pregnancy? It will decrease. Decrease. Residual volume will be going down. So this is wrong. Increase. So what will happen to the other things? Residual volume will decrease. Expired reserve volume will decrease. Tidal volume increase. Tidal volume go up. Inspired reserve volume will go up. So this part will increase, while tidal volume will increase, but expired reserve volume and residual volume will go down. Remember these changes. So what will happen to the vital capacity? So this part increase, this part decrease. What will happen to the vital capacity? Vital capacity will not change much. Will not change much. What will happen to the respiratory rate, Mithila? What will happen to the respiratory rate in pregnancy? Avanti, what will happen to the respiratory rate in pregnancy? Rate will not increase. This is a very common MCQ in your paper. Respiratory rate, now you know heart rate increase and all the parameters, most of the parameters in your body will increase during pregnancy, isn't it? But remember, respiratory rate will not. It will remain steady. Okay, Nuvantika, right? Respiratory rate will remain static during pregnancy. What will happen to the tidal volume? Tidal volume will increase. So have you all seen the pregnant people, how they breathe? How do you breathe, Mayuri, Manuri? When you breathe, you don't feel like you are breathing, isn't it? It happens automatically like this way. Nobody noticed that I'm breathing, isn't it? But when you're pregnant, how do they breathe? They breathe like this. Like that. They breathe like that. They take deep breaths. So what happened to them? Their tidal volume, sorry, tidal volume increase in pregnancy. Sudarshani, because of this thing, most of the pregnant women, they complain of some shortness of breath during pregnancy. They are otherwise completely well. Their heart is normal, their lungs are normal, the hemoglobin level is normal. However, they can get some kind of shortness of breathing during pregnancy because of increased tidal volume. This is another SPA in your exam. Okay, this is all because of these physiological changes. Right, okay. So increase residual volume, that is wrong. Increase and the glomerular filtration, urine production. What will happen in pregnancy? Remember, in pregnancy, almost all the organs in the body increase in size. Increase in size. So this is true. Your heart will increase, your kidneys will increase, your pancreas will increase, your breasts are enlarged like that. Increase lower esophageal sphincter pressure or sphincter tone. What will happen to the esophageal sphincter, lower esophageal sphincter tone? Have you all seen pregnant mothers? They almost always complain of reflux and GORD symptoms. Why is that? Sphincters are relaxed, especially lower esophageal sphincter will be relaxed. Who is responsible for this? Husband? No. Responsible. Who's responsible? Progesterone. Because of the progesterone. So increase lower esophageal sphincter tone, that is wrong. Reduction in uterine and cervical collagen. You know, in pregnancy, now before a woman becomes pregnant, what is the size of the uterus? It's just 50 grams. Make Kurumbatia size. Nobody will care. 50 grams. But when you become pregnant at term, it has gone up to 1,000 grams. So marked increase in size. This is because of increased collagen and increased muscle bulk. So this is wrong. Reduce gastric motility. Another complaint of pregnant women, they always complain of constipation. Why? The bowel movements are less. Who's responsible again? SLMC? No. Who's responsible? Progesterone. This is all because of progesterone. Okay. Second one, features of impending uterine rupture. Read the question carefully. This is Anuttari regarding impending uterine rupture. Okay. Features of impending uterine. What do you mean by impending? Like these days, some of the students might feel impending signs of failing exam. Impending features of passing the exam and becoming house officers. Something like that. Okay. So what is impending? It's not happened yet. It's about to happen. That's called impending. So impending features of uterine rupture. Is the uterus ruptured now? No. It is about to rupture. Continuous abdominal pain. Continuous abdominal pain. Now in pregnancy, in labor, they will get intermittent abdominal pains. But once the uterus is ruptured, they will get continuously pain. But this is after rupture. So this is not correct. Fetal tachycardia. Is it normal? Fetal tachycardia normal? No, it's abnormal. Again, this happens with uterine rupture. You can get tachycardias, you can get deceleration, reduced variability, all the CTG abnormalities. Again, not correct. Fresh vaginal bleeding. Yes, fresh vaginal bleeding you can get with rupture, not with impending rupture. Again, false. Hypotension. Why do they get hypotension? Because of the bleeding, internal bleeding. So that is after rupture, isn't it? Absence of palpable fetal parts. That means now when you do the vaginal examination, you would have fed the vertex of the baby. But after the rupture, head will be displaced, will be going into the peritoneal cavity. So when you do the vaginal examination next time, you won't be able to feel the head. So that is called displacement. So this is also a feature of rupture. What are the features of impending uterine rupture? This is non-specific actually. This is non-specific. You can get hematuria. Because the bladder is so close by. Okay, you can get hematuria and scar tenderness. This is non-specific. This does not mean always the patient is having impending rupture, but maybe scar tenderness, uterine scar, not the abdominal wall scar, uterine scar. Uterine scar tenderness. All the other features, what they have mentioned is not impending uterine rupture, after the uterine rupture. Yeah.
So what about the CTG changes?
CTG changes also. Now, why the baby get the CTG changes? It is because of some hypoxia. Why do they get hypoxia? When the uterus is ruptured, not with impending rupture. With impending rupture, I don't think that they will get the CTG abnormals. But once it's ruptured, yes. Okay. Right. Next one. Regarding epilepsy in pregnancy. Epilepsy in pregnancy. LSCS is indicated. When somebody is having epilepsy, does that means she need to be delivered by cesarean section? No, not always. There is no such indication. False. Max sulfate is used in the treatment. What do you think? Max sulfate is used in the treatment for epilepsy in pregnancy. According to your knowledge, Sachini, max sulfate is used in what condition? Impending eclampsia, okay, or eclamptic fits, something like that. Have you all heard about a condition called status epilepticus? That means that they get seizures and they are not recovering. They get continuously, seizure is continuing. So max sulfate has a role even within epileptic patients. So especially in status epilepticus. Frequency of epileptic seizures increase. In pregnancy, frequency of epileptic seizures can increase. Yes, true. True. Why? In pregnancy, they expose a lot of stress, especially in labor. There may be hypoglycemia, sleep deprivation, okay, pain. So all these things can precipitate seizure attacks. True. High dose of folic acid is recommended. Yes. What is the dose? 5 milligrams. Lamotrigine is considered to be less teratogenic. Lamotrigine is kind of a anti-epileptic liver, anti-epileptic treatment, but it is not usually used in pregnancy. It comes as category C. You know, in a drug by the FDA, they have categories A, B, C, and D. A means this drug can be given free without any problem, no side effects. B is there are some side effects, but those are not very serious side effects you can consider. You can give actually. Most of the drugs will come under this category B. Category D, what is category D? Absolutely contraindicated. You can't give at any cost. Contraindicated, absolute contraindicated. What is category C? It is between B and C, B and D. That is like relatively contraindicated. That means better not to give them. However, if there is no other option, you can consider. So lamotrigine will come under category C. So it is not less teratogenic. Question number 4. Scar tenderness, usually scar tenderness means something that you elicit. When you press the scar area, they get the pain. That is called scar tenderness. Tenderness means something that the patient is not complaining, right? Tenderness means now when you press it, when you elicit that sign. Question number 4. Poor progression of labor in the second stage is treated with. That means there's a patient in the second stage of labor or she's fully dilated, but labor progression afterwards, baby is not coming out. So what can you do? Amniotomy. If the membrane is intact, will you break the membranes? Yes or no, Manisha? Yes. If the membrane is intact, of course, you break the membranes. Yes. Augmentation with oxytocin. Now tell me, if somebody is having delayed second stage or delayed first stage, what will you do first? Taridu, what will you do first? Amanda, will you start with syntocinon? No. What will you do first? You do a vaginal examination and exclude cephalopelvic disproportion, CPD, features of obstruction. If those features are not there only, you can augment the labor. You can do amniotomy. You can start syntocinon. Yes, this is correct. Augmentation with syntocinon. However, remember, before that, you need to exclude CPD. Episiotomy. Second stage is delayed. You make, you know what is episiotomy, right? So you do episiotomy. Does that fasten the labor? Does that facilitate the labor or the delivery? Episiotomy means you make a cut like this. Does it? No, never, right? So episiotomy does not fasten the labor. It will not facilitate the delivery. What will it do? Main purpose of episiotomy is it can prevent, potentially prevent a major tear going towards the rectum. Because the rectum is here, anus is here, anus sphincter is there. When you make a pathway away from the anus, the chance of tear going into the rectum is less. That is the main purpose. So this is wrong. So this patient might come as in shoulder dystocia. By giving episiotomy, does it deliver shoulder dystocia? Poor progression of labor in the second stage is treated with manual rotation of the head. Yes. Now, if the baby is in occipital posterior position or deep transverse arrest, sometimes you can do the manual rotation. You can rotate the baby in occipital anterior position and that facilitates delivery. That's correct. Vacuum extraction, yes, it's an option. Question number 5. Which of the following is used in the management of preeclampsia in a woman with a blood pressure of 160/110 at 32 weeks? So, which of the following is used in the management of preeclampsia? So, they are talking about preeclampsia at 32 weeks with very high blood pressure, 160/110. Diclofenac sodium suppositories. Do you use NSAIDs in pregnancy? Non-steroidal anti-inflammatory drugs, anti or uncle inflammatory drugs. Do you use them in pregnancy? Why not? Diclofenac sodium, Brufen, those drugs, do you use them? Do you use them? No, you don't use them because it can cause closure of ductus arteriosus. That can be fatal to the baby. So you don't, it's contraindicated. What is the only drug, NSAID drug that you use in pregnancy? Aspirin. So diclofenac sodium you don't use. Intramuscular dexamethasone, she is 32 weeks having kind of severe preeclampsia, blood pressure is very high. Is there a place for dexamethasone? Dulana, is there a place for dexamethasone? Of course, yes. Because what is the treatment for this patient? Severe preeclampsia at 32 weeks. What is the treatment? Delivery. Before deliver, you have to stabilize the patient with what? Sulfate. To facilitate the lung maturity of the baby, you can give dexamethasone. So dexamethasone has a role. Do you give dexamethasone intramuscular or IV? Both. Both accepted. Okay. IV labetalol. Can you use labetalol to control blood pressure? Yes, possible. IV sulfate. Yes, definitely you have to use sulfate. What is the first drug? IV sulfate. If the blood pressure is still high, you can use labetalol, nifedipine, those drugs, hydrolysine. Sublingual nifedipine. Do you use sublingual nifedipine nowadays? No. What is the problem with sublingual nifedipine? It can suddenly, markedly drop the blood pressure. Suddenly drop. Because high blood pressure is beneficial to the baby. Otherwise, the baby will not get any supply. So if you drop the blood pressure markedly, it can lead to problem to the baby. So just give me 1 second. Sorry. Okay. So sublingual diptipine we are not giving because it can markedly drop the blood pressure. Oral diptipine, yes, but sublingual better avoid. Question number 6. Presentation at term favorable for vaginal delivery. Presentations at term means mature baby now. So after 37 weeks. Presentation at term favorable for vaginal delivery. Brow presentation. Brow presentation. Is it favorable for vaginal delivery? Brow presentation. What is brow presentation? What is the diameter of the head in brow presentation? This is the diameter. Vertical diameter. The largest diameter, 13.5. Can you deliver vaginally? No. Absolute indication for cesarean section. Sorry, yes. Brow presentation is false. Extended breech. Presentation at term favorable for vaginal delivery. What are the three presentations of breech? Presentations of breech. Two main presentations are extended breech. The knee joint is extended breech, and the other one is flexed breech. Which one is more favorable for vaginal delivery? It is the flexed breech. Is more favorable for vaginal delivery. So they said presentation at term favorable for vaginal delivery. Extended. Now, best thing to deliver is by flexed breech. However, extended breech also you can deliver. Okay, so as an answer, presentation at term favorable for vaginal delivery are they have given both answers: extended breech, flexed breech. So most favorable thing would be flexed breech. Foot limb breech you won't deliver; it's contraindicated, right? Flexed breech, yes. Mento anterior first presentation. What is this mento anterior? What is mento posterior? This is mother in the little patient. This is the anterior side. This is the posterior side. Mento means chin. When the chin is facing to the rectum, that is called mento posterior. Whereas it's on the other way around. When the chin is facing up, it's called mento anterior. Which one is favorable for vaginal delivery? Is this one or the other one? Mento anterior, ESM. Okay, mento anterior. When you have mento posterior, it should be delivered by a cesarean section. So this is wrong. This is correct, right? Mento anterior face, yes, favorable. Shoulder presentation. When the shoulder is coming, can you take the shoulder out? No, it's wrong. Question number 7. Shall all of us take a deep breath? Because I'm also going a little faster. Some people are yawning. Remember, you have your exam on Tuesday. Sad truth, isn't it? All right. Indication to use low dose of aspirin during pregnancy. She is asking, since we are delivering both extended and flexed breech, presentation at term favorable for vaginal delivery are. When you say favorable, favorable and unfavorable. When you say unfavorable, that doesn't mean you can't do it at all. Okay. So as answers, I think you can take both correct. But the best thing or the most favorable question will be flex reach. Question number 7. Indication for the use of low dose aspirin during pregnancy. Low dose aspirin. High parity. That means when you have the 5th pregnancy, 6th pregnancy, does it indicate aspirin? It's wrong. It's wrong. Increase umbilical artery Doppler resistance. Increase umbilical artery Doppler resistance. When will you do umbilical artery Doppler, Daru? How can you all remember about these things? This is the uterus. You have the uterine artery here, and you have the baby inside, and you have the umbilical artery there. Okay. When will you do umbilical artery Doppler? Or usually, when will you do umbilical artery Doppler? Umbilical artery Doppler you do when you are having a suspicion of IUGR, growth retardation, growth restriction. Okay, right? When will you do uterine artery Doppler? Those who are having high risk for preeclampsia, hypertension in pregnancy, you can do uterine artery Doppler in early pregnancy. When you do uterine artery Doppler in early pregnancy and the resistance is high, that is an indication for aspirin. You know, aspirin will minimize the chance of preeclampsia. And aspirin will reduce the chance of placental abruption and IUGR. Okay, so when you do uterine artery Doppler in early pregnancy, remember uterine artery Doppler in early pregnancy, if the resistance are high, that is an indication for aspirin, but not the umbilical artery. Because umbilical artery you do in later pregnancy, by that time, even starting aspirin will not help. So this is wrong. So read the question carefully. This is regarding umbilical artery, not about the uterine artery. Previous first trimester miscarriage. Is it an indication to start aspirin? No. Pre-existing diabetes mellitus. Yes. Chronic diabetes. Chronic diabetes, chronic hypertension, people with high risk of preeclampsia, obesity, that means BMI more than 35, obesity, elderly mothers, elderly primate, renal disease, SLE, those are all of them are indications for multiple pregnancy, soft markers for low dose of aspirin. When will you start aspirin in pregnancy? After 12 weeks. Till delivery, you have to continue it. Sinhala Theriya. Understood everything so far? Any doubts, you can send me a text later also. Then I will clarify it. Pre-existing diabetes mellitus, yes. Past history of SLE, yes, definitely. Risk factors for fetal growth restriction include gestational diabetes mellitus, fetal growth restriction, Bodini, FGR, gestational diabetes is a risk factor. Usually not. That is, the chronic diabetes is a risk factor for IOGR as well as macrosome. Gestational diabetes mellitus usually causes macrosome, rather FGR. So this is wrong. If it is chronic diabetes, yes, but not the GDM. Maternal short stature. Amma kotadayelle ekak nam baba IOGR wenawada. If the mother is a short mother, will that predispose to IUGR? Hatawal poda arina sudunonla mahattaru. ගල් ගිලලා වගේ මොකද පාඩම් කරපු දේවල් වැටේ කියලා දෙලියට. Yes, tell me. අම්මා කොට වෙන හැම එක්කෙනාගේම බබාලා IUGR වෙනවද? What can happen when the mother is short statured? Baby can be small, but small baby is not IUGR always. That is called small for gestational age. Baby can be small, however, otherwise normal. Unless there is a pathological reason, just because the mother is small, baby will not be IUGR. Baby can be small, that is true, but it's not IUGR. That is called constitutionally small baby. I don't have time to go into details because of this limited time factor, right? I hope you all can understand what I'm trying to say. Risk factors for fetal growth restriction include GDM falls, maternal short stature falls, recurrent antepartum hemorrhage. Yes. When there's a recurrent antepartum hemorrhage, that may increase the risk of fetal growth restriction. Fetal growth restriction, preterm labor, those risks are going up with recurrent antepartum hemorrhage. Renal disease, yes. Any maternal medical condition like renal failure, liver failure, heart failure, SLE, diabetes, hypertension, anything can predispose to FGR. True. Threatened miscarriage. What is threatened miscarriage, Taru? Early pregnancy, they have bleeding. However, the baby grows. That is called threatened miscarriage. Baby is live. Does that increase the chance of FGR later? Yes, there's a risk. There's a risk. Preterm labor again, and IUGR risk is slightly going up. Question number 9. Which of the following infections in pregnancy correctly paired with their complications? Cytomegalovirus, limb hypoplasia. Typically, you get limb hypoplasia with which infection, Sudarshani? Fingertip right? Infections are very important. You may get 1 or 2 cases from infections. All right. So you have to have it, right? Tasuni, Anutri, Dulana, Sadesh, both in anyone. In which condition typically you get limb hypoplasia? Chicken pox, varicella zoster, right? It causes skin scarring. Can you remember? Skin is like a map. India, right? So it's kind of a map on the body. Skin scarring and limb hypoplasia. That is typical of chicken pox. So cytomegalovirus, what do they cause? CMV, sensory neural hearing defects. Hearing defects they can cause. Listeria, neural tube defects. Listeria usually causes meningitis. Listeriosis, listeria meningitis, but it doesn't cause neural tube defects. Parvovirus, aplastic anemia. Yes, parvovirus can suppress the bone marrow. As a result, you can get aplastic anemia. When the anemia is severe, you can get hydrops, non-immunological hydrops fetalis. Immunological hydrops fetalis you will get with right? Immunological hydrops fetalis you will get in what condition? Manuri, RH negative mothers. Isn't it? Montessori lamanu danna me waden. Montessori ki lala balan kagaya. They also will be knowing these things. Okay, Rikas, right? And non-immunological hydrops fetalis typically you can get with parvovirus. What is the disease they cause? Parvovirus. That is slap cheek fever. Slap cheek fever you will get with parvovirus. It's not a teratogenic virus. These are all MCQs. It's not teratogenic, but it can cause aplastic anemia and hydrops. Okay, Avanti? Right, good. Rubella, sensory neural deafness. Yes, rubella also can cause deafness, cataract, heart problems. That is called what? Can I remember? පාඩම් කරන්නේ නැද්ද මේ ළමයි මොන් නෙවෙයි මේ ළමයි මේ ඇත්ත පාඩම් කරන්නේ නැද්ද මහත්ම මහත්මී you get a triad in rubella. What is that triad called? Yes, very good, Mithila. Excellent. Greg's triad. This one, eye defects, ear defects, heart defects. That is called Greg's triad. Okay, remember those things, Daruni. Those are hot questions in your. Now these answers, I mean, you know, right? Because you know definitely you will get an infection. Only few infections are there. So at least try to by heart these things before you go to exam. Varicella zoster, cataract. Cataract is not a common feature with varicella zoster. That is the chicken pox. They cause limb hypoplasia, skin scarring, and those things. Ophthalmia neonatorum will be caused by whom? Ophthalmia neonatorum, that means newborn born with crusted, thick secretions covering eyes, gonorrhea and chlamydia. Then අර කවුරු හරි කරපු lecture note එකෙත් ඔය දේවල් තියෙන්නේ. මම කරපු එකෙත් තියෙන්නේ නැති. කලින් කරපු ප්‍රශ්නවලදීත් ලියාගෙන නැති. දැන් අදත් ලියනවා. Next week you have your exam. Today also you will be writing down. And then ලියවිල්ල කවද නතර කරයිද කියලා. Right, okay. Question number 10 Darwin. Drugs correctly match with the fetal and neonatal effects. Doxycycline, discoloration of bone and teeth. Tetracycline, doxycycline, that category can cause these complications. True. Labetalol stillbirth. What does labetalol can do? Bronchospasm. They can exacerbate asthma in asthmatic patients, so you are not giving that. And they can cause IUGR sometimes, beta blockers. IUGR. Nifedipine, fetal bradycardia. No. What does nifedipine do in mother? Maternal tachycardia. Ondansetron, necrotizing enterocolitis. That means baby's gut necros. Typically, what causes this complication? Necrotizing enterocolitis. Because Krisani, Manuri, Avanti, Anjan. What typically causes? Yes, coamoxiclave. Very good. Coamoxiclave. You know, augmentin is a brand, right? Coamoxiclave can cause necrotizing enterocolitis. Very good. Sodium valproate, neural tube defects. Yes, it can cause cardiac problems, neural tube defects, anything possible. So Darwane, remember, right? If you don't have time, at least read these infections and have some common idea about few drugs that we use in obs and gynae. Only few drugs are there, not like medicine. Medicine, one number drugs, we don't use drugs. We use the finger, 2 fingers, right? In obstetrics. Right, so at least read few common side effects. Those are there in your handouts. Those are there in your the revision papers and all. Would have been done several times. So just go through them. You can definitely get questions with these topics. Question number 11. Increased FSH levels are seen in FSH, follicular stimulating hormone, right? You have the pituitary and you have the ovary. This is ovary. This is anterior pituitary. This is nothing else, right? Don't misunderstand. This is pituitary. Okay? Right. So, from the ovary, they produce estrogen and progesterone. Ovary produces estrogen and progesterone. With the stimulation of follicular stimulating hormone produced by the anterior pituitary. Anterior pituitary produce FSH, they go and stimulate the ovary produce estrogen and progesterone. Especially when the progesterone levels are going up, they go back and negatively inhibit anterior pituitary. Okay, that is a very common thing. So increased level of FSH seen in oral contraceptive pill used, OCP used. What does OCP contains? Estrogen and progesterone. So artificially you give estrogen and progesterone to the body. So what will happen to the estrogen and progesterone levels in your blood will go up. What do? They go back and inhibit pituitary. So as a result, FSH levels will go down. So this is wrong. Polycystic ovarian syndrome, PCOS. Patients with polycystic ovarian syndrome, they have more LH. The FSH also will be going up, but you have very significant rise in LH. So as an MCQ, right? Increase FSH levels in PCOS. It's true. But remember, it is more LH you have than FSH. As peer it is more FSH, not FSH, it's more LH you get with polycystic ovarian syndrome. However, you can get a little bit of FSH also in high amounts. Okay, Kuluni, fine? Right, good. Premature menopause, whether it's premature or mature menopause, when you are menopause, what will happen to estrogen and progesterone levels? Drops. So what will happen to the FSH production? Increase. That's how Bimalka you diagnose menopausal state by measuring FSH levels. So this is true. Sheehan syndrome. Sheehan, sorry, girls, you can pronounce it, right? Sheehan's. What happens in Sheehan's? Anterior pituitary will be necrosed. So all anterior pituitary hormones will be going down Wasantha. Okay. So including FSH, LH, TSH, not GnRH, FSH, LH, TSH, prolactin, ACTH, all these hormones will be going down. Turner syndrome. People with Turner syndrome, they are kind of like menopause. Ovaries are there, but streaky tiny ovaries, they don't produce adequate estrogen and progesterone. So as a result, FSH levels will be high. It's true. Question number 12. Okay. Regarding cervical carcinoma, early microdeposit spread is treated by horn biopsy. Early stage, stage 1A, microdeposit can be treated with horn biopsy. Yes, true. It's true. Remember, for cervical carcinoma early stage, horn biopsy is therapeutic as well. Especially if you want to preserve the fertility, you can do a horn biopsy. Hematogenous spread is rare. Yes, cervical carcinoma mainly spread by lymphatic. Herpes simplex virus DNA is found in the majority. Is it the herpes simplex? No. Human papilloma, HPV. Wrong. What are the subtypes? 16 and 18. Okay, Farzad? Yes, good. Squamous cell carcinoma has a better prognosis than adenocarcinoma. Yes. What is the commonest type? Is it the squamous type or the adenotype? Cervical carcinoma. Squamous is common. Prognosis is better than adeno. So this is true. Surgical pathological staging is the primary method of staging. Surgical pathological means that you do the staging of the disease while doing the surgery and with the histology. No, staging is a clinical, usually clinical staging. We do with this condition, cervical carcinoma is a clinical staging. Okay. Endometrial carcinomas, yes, it's surgical pathological. Endometrial carcinoma, surgical pathological, but cervical carcinoma is clinical. Question number 13. Leiomyoma. How the leiomyoma කියන්නේ? Manorige nangida myoma? No. Fibroids. In pregnancy, increase the risk of preterm labor. Fibroids in pregnancy increase the risk of preterm labor. No, it doesn't. It doesn't. Increase the risk of malignancy. No. Almost all leiomyomas are benign. Almost all. Very rarely, extremely rarely, it can become malignant, but leiomyoma increase the risk of malignancy. Multiparity is a risk factor. Fibroids. Multiparity is a risk factor. I'm not quite sure about that, right? I'll check it and let you all know, right? Give me a few minutes. Anyone knows the answer? Leiomyoma is common with multiparity. Multiparity is a risk factor. I can't remember it. I'm sorry. I'll check it and let you all know. Then regress with. Yes, I also think it's wrong, but I have to double check it. Okay, let me give me some time. Regress with ethinyl estradiol. No, fibroids are estrogen dependent tumors. So whatever the estrogen, they grow. That's why some of the fibroids are growing in pregnancy. And that's why when you are menopause, fibroids are shrinking in size. All because of their estrogen dependent. So this is wrong. Undergo cystic degeneration following menopause. Yes, of course, yes. Because when the estrogen is lacking, they undergo degeneration. What about fibroids? They are commonest monoclonal tumors. Commonest monoclonal tumors. Read your hand out. Right? And common among black Caribbeans. Black Caribbeans. Okay? Okay, Anjanan. Black Caribbeans, they have more fibroids than Caucasian Suddhas. Caribbeans got a characteristic දේවල් තියෙනවා, but it's more common. And common as monoclonal tumors, the incidence is about 40% among women. Most of the fibroids are asymptomatic. So unless they are symptomatic, you don't have to treat them. It is not capsulated, remember, but it can be easily enucleated. All these MCQs. Enucleated means you can take it out from the rest of the myometrium, but they don't have a proper capsule. Regarding HSG, hysterosalpingogram. Can I remember hysterosalpingogram? This is the uterus, the vagina. Tubes are there. Okay, in hysterosalpingogram, you inject a dye through the cervix, and the dye will be going like this, fill the cavity, and will be coming out from either end. This is the tubal assessment test, HSG. Hysterosalpingography, endometriosis is a contraindication. No. Can identify biconvate uterus. You know what is biconvate uterus? What is biconvate uterus? It has a septum in the middle. Yes, you can identify biconvate uterus by doing HSG. You can identify intracavitary polyps, fibroids, and all these things can be identified with HSG. When you take the X-ray after this dye, the X-ray will be like this in a normal person. This is HSG X-ray after the dye injection. You can see the front cavity. If there is a biconvate uterus, it will be like this. If there is a polyp inside, like this. So a lot of things you can diagnose with HSG. Endometriosis contraindications, no. Can identify bicontinence, yes. Performed during the luteal phase, latter part of menstrual cycle. No, all the tubal assessment tests are done in the early phase, proliferative phase. What is the reason? In the luteal phase, there is a possibility of pregnancy. But proliferative phase, they want pregnant, but the luteal phase, there is a possibility of pregnancy. Suppose there is early pregnancy here. When you inject the dye, this can go like this and this phase, and this can go and make an ectopic. Okay, right? And also it may damage the fetus also. So because of that, all the tubal tests, either lapenditis or HSG, hycosi, all these tests are done during the proliferative phase. Prophylactic antibiotics are recommended. Regarding HSG, prophylactic antibiotics are recommended. It's also controversial. Some people do, they do give, but some people don't give. So the thing is, if you have a suspicion about PID, pelvic inflammatory disease, better not to do it. But high risk people, you can give antibiotics and do it. Okay, but routinely you don't have to give antibiotics. Tube ovarian abscess is a complication, yes, because some of the organisms here, they can go along the tube and go into the pelvis and cause abscesses. Yes. What other complications can happen? Patient can go into vasovagal attack because when the cervix is dilating, it can activate the vagus system and bradycardia and hypotension you can get. Question number 15. Regarding contraceptive implants like Jadel. Okay, contraceptive implants. IMB is the commonest cause for discontinuation. What is IMB? Is the commonest cause for discontinuation. Contraceptive method. Commonest reason is breakthrough bleeding, irregular intermenstrual bleeding. Intermenstrual bleeding. Yes. Thank you, Sachin. Yes. If it is intermenstrual bleeding, yes. Because they can get irregular kind of sporadic bleeding. That is the commonest reason. Yes. True. Are less effective than intrauterine devices? No, this is very effective, especially Jadel, highly effective. One of the most effective contraceptive method, Jadel. Compared to Mirena and copper UCD, this is much effective. Less failure rates in adolescents than compared to OCP. Yes, less failure rates. That's true. Increased risk of ectopic pregnancy. Yes, all progesterone only preparations can increase the risk of ectopics. True. If it fails, can be safely inserted immediate postpartum. Yes. What are the contraceptives that you can be given, that you can introduce to a patient in the immediate postpartum period? Can you put IUCD, copper IUCD? Yes. Yes. Within first 12 hours, you have to put postpartum IUCD. Jadel? Yes. DMPA? Yes. What about OCP, Sachini? No. OCP is not given for the breastfeeding mothers, especially breastfeeding mothers up to 6 months. Even non-breastfeeding, you have to wait for 6 weeks because it increases the risk of thrombosis. Okay, Amanda? Because of that, OCP is not given postpartum. Question number 16. Risk factors for vaginal candidiasis are broad spectrum antibiotics. Yes. How? When you give broad spectrum antibiotics, knockout what will happen? they will damage, they will destroy the commensal important bacteria. When the commensals are destroyed, all the other non-important pathological virus and special bacteria and fungi, they can grow. So this is true. Diabetes mellitus, yes, well known. It's well known. Diabetes can cause vaginal candidiasis. DMPA, no. DMPA is not. Pregnancy, yes. Steroid use, yes. HIV, yes. What about OCP? OCP, yes, slightly increase the risk of candidiasis. Slight, but slight effect, okay? Regarding primary amenorrhea, diagnose if a girl does not menstruate by the age of 16. Primary amenorrhea. True or false? True or false? Anyone? Primary amenorrhea. Those days actually it was 16 years, but now people think it's 15 now. 15. So this answer, diagnose if a girl menstruates by the age of 16, by the age of 16. Can even consider as true, but now initially it was 16, but now it's 15. 1-5. Karyotype is a first line investigation. If a girl comes with amenorrhea, primary amenorrhea, karyotyping as the first line investigation. Will you do karyotyping? Yes, at one point you might have to do karyotyping, but that is not the first line thing. First line thing, you take a history and you do a vaginal examination, genital examination, you see secondary characteristics, and then arrange an ultrasound scan to see the uterus, to see the ovaries, and all. Presence of secondary sexual characteristic exclude XY genotype. Presence of secondary sexual characteristics exclude XY genotype. Can a male, that means male means XY, coming with like a exact female with primary amenorrhea? Yes. What is that condition?
Androgen sensitivity syndrome.
Very good. Androgen insensitivity syndrome. They are like perfect females, one of the best looking females. Boys, you can list your girlfriends and see who's the most beautiful one. Maybe X5 female. Okay, so they have most of the secondary sexual characteristics, but they can be still XY. They don't have a uterus. So this is wrong. Transvaginal septum is a cause, yes, because sometimes they have everything cleared, but hormonal pathway is clear, but they have a septum here. So they can, even though there's menstruation, this blood will not come out, they will be going back and collect in the uterine cavity and in the peritoneum. Okay, so they will get cyclical low abdominal pain, either transverse vaginal septum or imperforated hymen. Then imperforated hymen will doctor they get done some other things and anyhow they get the bleeding, but this is also a non-trace. How will you differentiate imperforated hymen from transverse vaginal septum? Anyone? In transverse vaginal septum, you will get a pinkish color bulge. Whereas in imperforated hymen, you will get a bluish color bulge. Undernutrition is a non-cause. Yes, true. Malnutrition, undernutrition actually is a non-cause for primary amenorrhea. Drugs that are used to treat vasomotor symptoms in postmenopausal women with intact uterus include HRT in a woman with intact uterus. When you have intact uterus, can you give estrogen only preparations? No. Why? Why is it me not? When you give estrogen only preparation, it causes endometrial proliferation, endometrial hyperplasias, and endometrial cancers. So you have to always combine estrogen with progesterone. So what is lacking in menopause women? Estrogen. So what you have to replace then? Estrogen. If there is no uterus, if the patient had underwent hysterectomy, then you can give estrogen alone, less side effects. Whereas if there is a uterus, there will be endometrium. If you give estrogen only, it can proliferate and cause cancer. So you have to combine with progesterone. So drugs to treat a woman with intact uterus. With intact uterus. Bisphosphonate with your surgery and medicine knowledge. Bisphosphonate is used for what? Surgery. Bisphosphonate to reduce the activity of osteoclast. That's thereby to prevent osteoporosis. So menopause women also you may have to use this bisphosphonate, but if there is osteoporosis, not for hot flushes. Clonidine, yes, this is an alternative for hormonal HRT. Fluoxetine, antidepressants, yes, you can use. Estradiol alone, for this particular patient, you can't use alone. False. Venlafaxine, that is also an antidepressant drug that can be used, like fluoxetine, you can use to minimize these side effects. True. Risk factors for overactive bladder syndrome include risk factors for overactive bladder. What happened in overactive bladder, Daru? Bladder is so irritable. Always contracts. So irritating. These days, you guys may be also irritating. Something like that. You become irritable when you are under stress. So why the bladder get this irritability? Bladder calculi, yes, right? When you have bladder calculi, especially girls, when you have calculi, how do they walk? They walk like this. What will happen to the stone? The stone within the bladder also will be moving this way and that way, this way and that way. What happened? It can irritate the epithelium inside, transitional epithelium, and stimulate contractions. Okay, it's true. Tumor can cause the same thing. Stone can cause the same thing. Infections can cause the same thing. So, bladder calculi, yes. Diuretic therapy, yes. Hysterectomy. Can it irritate the bladder? Yes. How? How? Sudarshani, how? Tarandu, how? Bladder is very close to the uterus. During surgery, you have to mobilize the bladder. You have to cut the peritoneum and you have to push the bladder down, if you have seen it, right? So when you mobilize the bladder here and there, it can irritate and cause these problems. True. Menopause, yes, estrogen deficiency can irritate the whole woman. And their bladder as well. Estrogen නැති වුනහම යන අයට තිසු හැදෙනවා. They become so irritable. දැන් ඔය ළඟට වෙලා මගේ සුදු රත්තරන් කියලා හිටියට when the estrogen is deficient, they become so virulent, including their bladder. Smoking, yes. So girls, don't smoke. Iya halo, pina smoke karan. somebody like that, right? So smoking can irritate the bladder. True. Complications of spinal anesthesia in cesarean section are chronic lower back pain. Yes, sometimes, rarely, patient can get chronic lower back pain. Headache within 48 hours. What is that called? Spinal headache. So when you pierce the meninges, they leak the CSF, subarachnoid space. The CSF will be leaking. When the CSF is leaked, they can get headache. That is called spinal headache. What is the treatment for spinal headache? Maybe SBA. Hydrate the patient. Yes, very good. Hydrate the patient. Give painkillers. If not responding, what is the last option?
Spinal patch.
Spinal patch. Who's this brilliant boy? I can't see his face.
Anjana.
Who's?
Anjana.
Anjana. Very good. Spinal patch. Okay. So if you have gone through the mixed revisions and these revision patients, you would have mentioned there. All right. Okay. Complications of spinal anesthesia, chronic back pain, yes, headache, intraoperative bradycardia. Intraoperative, yes. There's a thing called high spinal. You get the spinal level up to around this level, T10, umbilicus. If it is going up and up and up and up, it can suppress your sympathetic system and patient can get bradycardia, hypotension. That is called high spinal. It's true. Intraoperative hypertension. No, it is hypotension. Urinary retention, yes. That's why when you do the spinal surgeries, you usually put a catheter inside to drain the bladder. Okay, Darwani. So we have done this MCQs. I think 40 MCQs we have discussed. So if you all have doubts, you can clarify now, or you can send me a text later. I will clarify those. And we'll move on to the SPS. And before that, shall we take 10 minutes break? Is that okay? Yeah, 10 minutes break, right? Okay, shall we start now? Hello. Shall we start now, Darwin? Is the time factor is very important and it's limiting now. So we'll start. SPS. Now, when it comes to MCQs, right now you will be having your exam in a couple of days' time. So when you are answering for MCQ for the first time or the second time, right, whatever it is, right? So if you take a particular question, say for example, if you take question 1, if you know 3 answers correctly with confidence, you're pretty sure these 3 answers are correct. Out of 5 options, 5 steps, you have 3 got correct. If it is 3 correct for sure, don't try for a 4th or the 5th one. That means if you are trying for the next one, if that is not sure, then you will be having more problem rather than remaining with that 3 solid answers. So if you take MCQs, my advice is that if you know 3 answers correctly for a sure, don't try for it, don't guess the 4th or the 5th one. Right? You have to be satisfied with 3 answers. That is enough. For example, if you know only 2 for a sure, then of course, I think better to try for a next 1 or 2. But if you have 3 for a sure, if you know 5 out of 5, then that is much better. I mean, no doubt about it. But say for example, if you know only three correct answers, but you are sure those are correct answers, then mark those 3. Don't try for a 4th one or the 5th. Okay, right? Clear. So shall we move on to these SBAs? Question number 21. A 34-year-old primary mother presented at 8 weeks of gestation for a booking visit. What is the best method of screening for trisomy 21? Trisomy 21, what is the best option for this particular patient as far as the Down syndrome is concerned? She's 34 years old, so probably having a risk of Down syndrome, right? Because she's relatively, her age is high, and she's 8 weeks of pregnancy. Combined test done between 11 to 14 weeks, 30 plus 6 means 14 weeks. 11 to 14 means combined test. What is combined test, Daru? You combine 2 things. What are you going to combine? You combine the ultrasound findings with the serological markers. That is the nuchal thickness with some of the biological serological markers of the mother. So that is called combined test. When can you do this combined test? 11 to 14 weeks. Is it correct? Yes. Because nuchal thickness, best time to check the nuchal thickness is 11 to 14 weeks. So you can do the nuchal thickness and you can do some of the biological markers and you can combine together. So this looks correct. We will see the rest. Double marker test, double marker assessment, double test, in Down syndrome screening. If you can't remember, please go through your antenatal care and the last page I have given like in a table. What is combined test? What is double test, triple test, quadruple test? Okay, please go through this. What are the markers? These markers also can be questioned, like inhibin A, like estriol, like all those kappa A. Those there are various markers. So what they say in the second step is double test marker assessment in the first trimester. Usual double test marker assessment is usually after 15 weeks, 15 to 22 weeks. So it is relatively later. Triple marker test assessment at 15 weeks. Yes, triple markers also you do after 15 weeks. But combined test you can do in the first trimester itself. 11 to 14 weeks, first trimester and early second trimester, you can do the combined test. Nuchal translucency assessment between 11 to 14 weeks. Yes. If you take nuchal thickness alone, and if you take combined test, what is more sensitive? combined test is more sensitive. That's biological markers plus nuchal thickness. Quadruple test done at 18 weeks. So they are asking what is the best method? So I think it's the answer A is correct. Combined test. Question number 22, sorry. 32-year-old pregnant woman in a second pregnancy presented to the antenatal clinic at 28 weeks. The Rh antibody titer is 164. So she is now sensitized Rh negative mother. What is the next step in her management? She is now sensitized and she is 28 weeks of pregnancy. Rh negative mother. What is the next step in the management? Dexamethasone. Will you consider giving dexamethasone for this patient or not? Is there a risk of preterm delivery? Oh, you have to deliver this patient preterm. Is there a risk? Yes, because she's Rh sensitized. If the baby develops anemia, either intrauterine transfusion or delivery. Okay? So delivery is also an option. So you have to get ready. You have to do dexamethasone. That's correct. Perform amniocentesis and measure bilirubin level in the amniotic fluid. Is there a place for amniocentesis in Rh negative mothers? Yes, especially when you are going to do intrauterine transfusion, you have to know the packed cell volume and the degree of hemolysis. So there is a place for amniocentesis, but amniocentesis is not going to be the next step. It's an invasive procedure. Photosynthesis, the same. Measure middle cerebral artery systolic velocity. Why? Why you want to do that? Yes, you have to do that. Because by doing middle cerebral artery Doppler, you can detect fetal anemia. That is one of the main important, simple, non-invasive investigation that you can do. Repeat antibodies in 2 weeks. Yes, you have to repeat antibodies in 2 weeks. That's true. But before that, Darwani, if there is a sensitized mother, you have to first of all, you have to see whether the baby is affected or not. Do a detailed ultrasound scan, see whether any features of hydrops. And if there are no features of hydrops, see middle cerebral artery Doppler. So read your Rh negative mother. Rh negative mothers, you can get questions like this way. Non-sensitized Rh negative mothers, what are the routine things that you do? You check antibodies at book-in visit, 28 weeks, 28 weeks, 36 weeks. Like that, you check antibodies and you give 2 doses of prophylactic program. After delivery, check the baby's blood group. If the baby is positive, give another dose of program. That is the management. Then you have to see sensitized Rh negative mother like this. With affected babies around 28 weeks, best thing is intrauterine blood transfusion. If the baby is closer to 32, 33 weeks like that, best thing is delivery and extrauterine blood transfusion. So revise your Rh negative mother. Definitely you will get a question. Those are the only 3 scenarios that you can get with Rh negative mother. Question number 23. So out of dexamethasone and this thing, what is most, what should be your next step actually? Giving dexamethasone or doing middle cerebral artery Doppler? Doing middle cerebral artery Doppler is much more relevant for this case. And I forgot to mention you all regarding fibroid, that MCQ. Multiparity is a risk factor for fibroid. Yes. For both adenomyosis and fibroids, multiparity is a risk factor. Question number 23. A 37-year-old primate presented with intermittent pervaginal bleeding at 37 weeks of gestation. So she is elderly, 37 years old, like Erpm students after completing Erpm in 10 years time, right? They will be elderly primate. So 37 years old, 37 weeks, coming with recurrent episodes of PV bleeding. On abdominal, on examination, no abdominal tenderness was noted. Abdomen is not tender. What are the two main differential diagnoses, or maybe three main differential diagnoses for antepartum hemorrhage? Placenta previa, this is antepartum hemorrhage, isn't it? Placenta previa, placenta abruption, vasa previa. How to differentiate previa from abruption? Abruption, you will get a severe abdominal pain and tenderness, woody hard tenderness. Whereas placenta previa, painless. Abdomen is like a velagadia, varakagedia, soft. Abdomen is soft, velagadia, right? So in placenta previa, abdomen is soft, whereas in abruption, abdomen is very tender and woody hard. So on examination, abdomen is not tender, no abdominal tenderness, and she had the blood pressure of 90/60, was lower side, and the pulse rate is high. That means she would have had a significant amount of bleeding. That's why her blood pressure is low, pulse rate is high. What is the next step in the management of this patient? So is this more likely placenta previa, abruption, or vasa previa? And I need the justification. Why you say like that? Hands up, those who say this is placenta previa. Why Farzad? You said this is placenta previa. This is because of no pain and tenderness. Agree? What else? Vasa previa also no pain. Why this is not vasa previa? In vasa previa, you get the bleeding from the baby. So mother's blood pressure will not change. So this is not vasa previa because mother maternal blood pressure has gone down, pulse rate has gone up. So this is bleeding from the mother. So it looks like placenta previa. Okay. What is the next step in the management of this patient? Arrange an ultrasound scan to exclude placenta previa. Will you do ultrasound scan in this patient? Yes or no? How will you confirm your diagnosis of placenta previa? Manuri, how will you confirm, Daru? Sachini, Amanda, Vimalka, Vikas,
Clinical
Prashant?
diagnosis.
Huh?
Clinical.
No. Placenta previa is ultrasonic diagnosis. You need ultrasound. You must have an ultrasound. Abruption, what you are going to try to say is abruption is a clinical diagnosis. If a patient come in with painful bleeding and fetal compromise, that is until proven otherwise abruption. But placenta previa, for you to come to diagnosis of placenta previa, you need ultrasound scan. So, will you arrange ultrasound scan? Yes, you do. Perform vaginal examination to assess the Bishop's score. If you suspect placenta previa, will you do vaginal examinations? Absolutely contraindicated. Anit ඕනම වෙලාවක as VOGs, we can do vaginal examination in any women, but not in placenta. Husband you can do vaginal examination, but remember, in placenta previa, if you suspect, no digital examination. But you can put a speculum if you want. Turn the patient into lateral position. I mean, any pregnant woman after 20 weeks, you should be nurtured in the lateral position. That is true. Okay, you take it as true. Take blood to exclude coagulation failure. Coagulation failure in what condition you will get coagulation failures, Daru? Mainly abruption. Abruption can cause sudden DIC. Give a rapid bolus of 0.9 saline. Now, whatever it is, whether it's abruption or previa or whatever the kehemmala, you know, is this patient is stable or unstable? Put your legs up if you say this patient, not hands up, if you say this is an emergency. Yes, this is an emergency. Why you say this is an emergency? Because the blood pressure is low, pulse rate is high. So that means patient is in impending shock states. So we don't mind about the underlying pathology, but the patient is unstable hemodynamically. So where you should start? Your resuscitation, airway, breathing, circulation. If the patient is talking with you and giving all the history and all, the airways is okay. හොඳට කතා කර ඉන්න patient කෙනෙකුගේ airway manage කරන්න කියලා tube එකක් දාන්නේ නැහැ. Right? So airway is okay if you talk with the patient and if she can communicate, airway is not a problem. Then the breathing, patient may be breathing like, Dr. Tika, something like that. So to facilitate the breathing, you can give oxygen. Mouth breathing then you have wall oxygen, so you can give oxygen. Next thing is the circulation. Is she having a problem with the circulation? Yes, of course. She's having bleeding and blood pressure is low, pulse rate is high. So what will you do? Put 2 white-core cannulas, same time withdraw blood for cross-matching and start crystalloids. Till the blood is available, you can start with saline and resuscitate the patient. So we don't mind underlying condition, whatever it is, you have to first resuscitate the patient. So what is the best answer out of all? The last one. In our paper classes, I would have emphasized this fact several times, right? So in this case, actually, you don't have to know what is the underlying condition, whether she is having abruption, previa, whatever it is. But if you have a small IQ, you know the patient is unstable, so you have to resuscitate the patient. Okay, right? Good. Question number 24. A 35-year-old primate with a BMI of 33, chubby girl, 35 years old primate, BMI 33, attended to the routine antenatal clinic at 28 weeks. And OGTT was performed and the fasting blood sugar level was 129. The amniotic fluid index was 28. What is the normal amniotic fluid index? A5. 5 to 25 is normal. AFI, 5 to 25 is normal. Less than 5 is called oligohydramnios. More than 25 is called polyhydramnios. So what she is having? She is obese lady having polyhydramnios and fasting blood sugar also high. She's 28 weeks. What is the most appropriate option for her? So since the fasting level is high, no GTT, you can say she's diabetic. The baby is having polyhydramniosis. So looks like uncontrolled diabetes. Advice on to reduce weight. In pregnancy, can you all easily reduce your weight? Girls and boys, think of yourself. I suppose you all are not pregnant yet. Try to cut down your body weight. Is that easy? No. Can you do that in pregnancy? No, not at all. And it is not recommended also. Okay, this is wrong. Insulin. What are the 3 options to treat diabetes in pregnancy? Lifestyle modifications and medical nutrition therapy, that is diet control, metformin, insulin. Okay, leave insulin for the time being. Lifestyle modifications. Will you ask this patient to do lifestyle modifications like burger kanne pa, kottu kanne pa, like that, dietary advices, smoke karanne pa. Girls are smoking in Sri Lanka, right? Quite a lot larger proportion. So stop smoke and all these advices will you give? Yes. All pregnant mothers, whether they are pregnant or non-pregnant, when they are diabetic, you have to give those things. That's also true. Medical nutrition therapy. Diet take a control karanna. Yes. Metformin. In this patient, will you give? Now, when you diagnose diabetic, all pregnant women should be given medical nutrition therapy. Diet control advices you have. If the blood sugar levels are not very high, this MNT alone may be enough So you review the patient after 2 weeks and do a BSS in 2 weeks time. If the blood sugar levels are under control, she can manage with MNT. And you every 2 weeks you reassess the blood sugar levels. After 2 weeks, if the blood sugar levels are high, you add metformin. And review in 2 weeks time, how is the blood sugar levels, BSS. If that is control, you continue diet plus metformin. If it is still high, you add on insulin. As the third line, you add insulin. And time to time, you can adjust the insulin dose to achieve the glycemic control. Okay, this is how we manage diabetic patients in pregnancy. Everybody should be given MNT, and if the control is not good, you can add metformin, and if the control is not yet good, you can add insulin and adjust the dose. However, Darwo, if the values are very high at the beginning, like this patient, and if the baby is affected like polyhydramnios or macrosomia, if the baby is having polyhydramnios or macrosomia, better to start insulin at beginning. Insulin should be the best treatment for that kind of people. So this baby is having polyhydramnios. So she needs medical nutrition therapy, no doubt about it, but best thing would be insulin. Okay. Okay, Litma Kumara Dasa, right? Clear? Clear do? Bimalka? Good. Yeah, හුස්මක් එහෙම ගන්න ඕනේද නිකන් නිින්ද යාගෙන වගේ එනවද? ඒ අම්මා බත් එකක් එහෙම බෙදලා දෙන්නේ නැත්නම් තඩි බත් එකක් කාලා නීමි. Okay, ESM. Right. On to the next one, Daru. 25. A 40-year-old woman who conceived using in vitro fertilization, IVF, at 28 weeks of period of gestation with blurred vision and epigastric pain. IVF pregnancy, elderly mother, so she would have been subfertile, 40 years old, IVF pregnancy. Now she is 28 weeks, having epigastric pain and blurred vision. On examination, she had bilateral ankle edema. Blood pressure, again, very high. Exaggerated reflexes. What is the next step of management? What are all these features? Epigastric pain? No, this is not eclampsia. Epigastric pain, blurred vision, exaggerated reflexes. What are they called?
Impending
Eclampsia.
eclampsia.
This is called, very good, impending eclampsia. This is not eclampsia yet, but she's having a very high risk. In the next moment, she can throw on a fit. This is called impending eclampsia. If there are features of impending eclampsia, what you have to do? Anyway, in preeclampsia, what is the treatment? Delivery. Delivery is the treatment for preeclampsia. If there are impending features, impending eclampsia, you have to arrange an urgent delivery. Before delivery, is this patient stable? Is this patient stable? No, her blood pressure is very high and she is having impending features. So she is not stable at all. So you have to make her stable. Stable කරන්නේ කොහොමද? රනිල් පාර්ලිමේන්තුව stable කරන විදියටද නැහැ. How are you going to stabilize this mother? What is the marvelous drug? Start Maxalfate. By starting Maxalfate, you can temporarily halt the disease process from preeclampsia to eclampsia. This is going from preeclampsia to eclampsia. You can temporarily halt by giving Maxalfate. Preeclampsia eclampsia. This transition can be temporarily blocked by max sulfate. Okay, max sulfate was also not a permanent solution. It's just to stabilize. IMF loan එක හම්බෙනකන් දුව ගන්න වගේ තමයි තියෙන්නේ. It's not permanent, it's temporary. Okay, so this mother, a precious pregnancy, IVF, elderly, this may be her last hope. She's 28 weeks, having severe preeclampsia with impending features. Are you going to deliver this mother? Precious pregnancy. ලක්ෂ ගාණක් වියදම් කරලා ඉන්නේ. පොලියට සල්ලි අරන් IVF කරලා තියෙනවා. Still 28 weeks. Baby is not yet mature. Will you deliver this mother or will you wait and see? නියපොතු හපන ගමන් මූණු කඩන ගමන් tell me the answer. Will you deliver this mother or will not? කාගේ වුණත් ළමෙක්නේ පව් නැද්ද? ඔච්චර වේදම් කරලා සෆර්ටයිල් වෙලා ඉඳලා සති 28 ඩිලිවර් කරලා මැරලා ගියොත් එහෙම ඔය පීඩියාට්‍රික් කියුම් කෑ ගැහුවට can they make them survive at 28 weeks? Very difficult. ඔය කියන්න ඕනේ නැහැ ඒගොල්ලන්ට ගිහිල්ලා. Right? So will you deliver this baby or not? You must deliver. Because in obstetrics, there is no mercy for the baby. You know, first think about the mother. Mother first. If you are not going to deliver this baby, mother can develop eclampsia and mother can die. So we can't think about, unfortunately, we can't think about the baby at the moment, but we have to think about the mother. Always mother first. Okay, right. So in this condition, irrespective of the baby's condition, you must consider delivery. So. What is the next step of management? Next step, they're asking the next step. Immediate delivery by hysterotomy. Hysterotomy means what? In early pregnancy, when you do cesarean section, it's called hysterotomy. Same thing. IV max sulfate, IV leptolol, IM dexamethasone, CTG. Oh, no, Montessori, you have to start max sulfate as your next step. What is your best step? Delivery. What is your next step? Max sulfate. Again, dexamethasone, of course, you have to do dexamethasone, Dargo, but main concern is for the mother. Max sulfate, no, if you give dexamethasone, it won't work. At number 27, a lady who underwent hysterectomy was given morphine for pain relief in the gynecology ward. She was found to be drowsy with pinpoint pupils and the respiratory rate was low. What is the best treatment for this? When you give morphine, one of the complication of morphine is respiratory depression. So this is not common, even though the question says this is not common. But what is the antidote for opioids? Naloxone. Sorry. Anyway, we'll go back to number 26 again. 27 answer is naloxone. The Samara students shape right, question number 26. Sorry. A 40-year-old multipara presented 2 weeks after normal vaginal delivery, fever and reduced urine output. So she delivered 2 weeks ago, now coming with reduced urine output, vaginal, fever and reduced urine output. On examination, patient was pale. Her temperature was 38. She is having fever. Pulse rate is high. Blood pressure is stable. 100/70 means stable. Her lower abdomen was tender. What is the most appropriate management? So what is this condition, Daru? What is this condition? After delivery, fever, abdominal pain, and ill-looking lady, tachycardia, yes, postpartum sepsis. specifically, what is this? Tender lower abdomen. Endometritis, infection within the endometrial cavity, common endometritis. Postpartum sepsis, first thing you have to explore is endometritis. What are the other causes for postpartum fever? Endometritis is number one. UTI, breast engorgement, breast abscess, and don't forget DVT. DVT also can present with fever and malaise and all these features in postpartum period. So don't forget about fever also. So is this patient hemodynamically stable? Yes, blood pressure is okay, even though she is tachycardic. You all know that when there's a sepsis, when there is fever, anyway, your pulse rate is going up. What is the most appropriate management option? A, arrange for immediate evacuation of retained products of conception. When there is a sepsis going on, you don't immediately go and evacuate the uterus, because you can perforate the uterus and you can worsen the condition. So never do that. Even in septic abortion also, when there is a septic abortion, patient is unstable and having high fever and all, you first start antibiotics and all, stabilize the patient, and later consider evacuation if necessary. Perform urgent ultrasound scan. Yes, you need to arrange an ultrasound scan. Broad spectrum antibiotics. Start IV fluids. Urgent blood transfusion. Does this patient need blood transfusion at the moment? Not really, because her blood pressure is stable. Does this patient need IV fluid as the first line? In sepsis patient, you tend to give fluids. That's true, but she is hemodynamically stable at the moment, not in a hurry, not in an urgent. What about antibiotics? First thing is that you have to take cultures. All the cultures is not given here. So you have to take all the cultures, including the swab, and you have to start broad spectrum antibiotics. That is the best management. Start broad spectrum antibiotics. And then give fluids and do ultrasound scan and see whether any retained products inside. And once the patient is stable, you can go for evacuation later. Question number 27. 27 we discussed. 28. 38-year-old second para presented with spontaneous onset of labor and gave consent for vaginal delivery, breech delivery. This is a singleton fetus in extended breech presentation. Cervical dilatation is 5 centimeters and breech is 1 centimeters above the skull spine. Membranes are intact. She has 3 contractions in 10 minutes and fetal heart rate is normal. So this is an extended breech presentation. She gave consent for breech delivery and the baby is stable at the moment. Estimated fetal weight is 2.8, average size baby. Antenatal period is uncomplicated. A previous pregnancy resulted in uncomplicated vaginal delivery of 3.2 kilogram baby. So she had delivered fair size of baby last time. That means her birth passage is adequate. What is the most appropriate management option for her now? So she is a breech, 5 centimeters dilated, getting contractions, intact membrane, giving consent for breech delivery. Administer pethidine. What is pethidine? Painkiller. Will you give pethidine? Yes, you can give pethidine for pain relief. But remember, when you give pethidine, you're get ready with naloxone, because if the baby is delivered soon, the baby should be given reversal. Pethidine is okay. Allow the labor to progress and review in 4 hours. At the moment, baby is stable. Mother is consenting for breech delivery. So you don't do anything now, you wait for 4 hours. Perform amniotomy. Remember, one of the theory in breech delivery is no induction, no augmentation. By doing amniotomy, you are going to augment the labor. No, so you should not do that. You have to wait till the spontaneous rupture. Start an oxytocin infusion, no augmentation of labor, no oxytocin in breech. Perform ECV, external cephalic version. All breech deliveries Daruo, if the membranes are intact and if there are no contraindications, you have to try for a ECV, external cephalic version. But the scenario is different here. She has gone into the labor and she is in the halfway of the labor, 5 centimeters dilated. Okay, and she's getting contractions. When the contractions are there, it's practically very difficult to do external cephalic version. When the OSCE is dilated, when she's getting contractions, ECV is not possible. So what you have to do? So far, other than being a breech, everything else is under control. Baby is in a good shape, pelvis is adequate, labor is progressing. So what you have to do? Don't do anything, you just wait and see for 4 hours. And reassess in 4 hours time. Because in labor room, unless there are indications, you review in 4 hours time. Question number 29. A primigravida presented with a fetus in occipito-posterior position. Cervix is fully dilated despite of 1 hour active pushing. The presenting parts have not descended. What is the next step in the management? This is OP, occipito-posterior. What is occipito-posterior, Daru? The baby's face in this face is the nose, eyes, right? Baby is facing up, and this is the back side. Occipit is posterior. Usually, occipito-posterior deliveries are difficult. Spontaneous delivery is difficult. So what are the options when you have occipito-posterior position? You can manually rotate the baby in occipito-anterior position and take the baby out. Manual rotation, possible. Or else, you can use kiwi cup, vacuum. You can apply the vacuum and you can rotate the baby and take the baby out. If not, if the OP position is persisting, better to go for a cesarean section. Better to go for a cesarean section. You will see. Yes. What is the next step? They're asking the next step in the management. Assess the features of obstruction. When there is a delay in labor, either first stage or second stage or whatever it is, what is your next step, Daru? Do a vaginal examination and exclude cephalopelvic, severe cephalopelvic disproportion. See whether any severe molding, cervical edema, all these features we have to see. Yes, this is very correct answer. We'll see. As the features of obstruction, cesarean section. No, that is not the next step. Augmented cytosine, no. If it is still OP, no point of starting oxytocin. Put her into knee chest position. That is in shoulder dystocia. Vacuum extraction. What is the next step? What is the next step? Is it the vacuum or is it the vaginal examination? Best thing is do a vaginal examination. Vaginal examination. So please remember that whatever the delay, first do a vaginal examination and exclude CPD. Very important. Me, right? Okay. Now I'm comfortable. Right. Okay. So do a vaginal examination. So that should be the next step. Question number 30. A 30-year-old multipara presented with spontaneous rupture of membranes at 37 weeks. The fetus is in cephalic presentation. There are 3 contractions in 10 minutes. The CTG shows atypical decelerations. What is your next step in management? Right? Okay. Even though if you don't know what are atypical decelerations, now you know there are 3 main types of decelerations. No, early, late, variable. Variable decelerations, there are atypical decelerations. Atypical means variable decelerations mean these are the contractions. You don't know, you can't predict at all these decelerations. It may come before the contraction, it may come with the contraction, or it may come after the contraction. And the amount they going down also varies from B to B. These are called atypical variable deceleration. You don't have to remember about those things. Anyway, these are variable decelerations. So she is having spontaneous rupture of membranes, 37 weeks, getting contractions, cephalic presentation, CTG showed atypical variable decelerations. What is the next step of management? Arrange emergency cesarean section, commence high flow oxygen, commence intravenous saline, do a vaginal examination, keep her in lateral position. See the same clinical theory they are asking in 2 patients. When you have a delay in labor progression, when you have CTG abnormality, what should be your next step? Do a vaginal examination. Why you want to do a vaginal examination in this case? Why you want to do a vaginal examination in this case? Anyone?
To exclude cord prolapse.
Exactly, to exclude cord prolapse. Good. The history also says she had ruptured her membranes, so maybe the cord would have come out. So good. Question number 31. 25-year-old primary presented to antenatal clinic at 10 weeks. She is diagnosed patient with beta thalassemia minor. Beta thalassemia minor. And she is worried about that her baby will be affected. What is the next step in the management? Beta thalassemia, how will you get the transmission? It's autosomal recessive. Autosomal recessive. Right? So mother is a carrier. Or she's the beta thalassemia minor. So she is a beta thalassemia carrier. Suppose this is the normal gene, this is the abnormal gene. So she is having both a normal gene and an abnormal thalassemia gene. So since she is having a normal gene, she won't show features of thalassemia. However, she is having the abnormal gene as well. Suppose husband also a carrier like this. What will happen? They can babies like A, normal, A, simple A, again a carrier, A, simple A, again a carrier, and you can get AA also, thalassemia major. So wife is a carrier and husband also a carrier. In that case, there is 25% chance baby can be thalassemia major. 50% chance baby can be thalassemia trait. 25% chance baby can be completely normal. Because this is autosomal recessive transmission. So what is the next step in the management? Amniocentesis at 15 weeks. Next step, amniocentesis is an invasive procedure. Okay, it's an invasive procedure. Chorionic villus sampling, again, an invasive procedure. Remember, chorionic villus sampling is done after 10th week. Amnio is done after 15 week. Maternal genetic study is a carrier. We know that she's a carrier. It's given. Reassure that child would be healthy. No, you can't reassure, because if the father is a carrier, there is a 25% chance baby can be thalassemia major. Paternal hemoglobin level. Yes, you have to do a paternal hemoglobin level first. If the hemoglobin is low, you have to do the genetic assessment of the father. If the father is normal, suppose if the father is normal, mother is a carrier, father is completely normal. This is father. This is mother, is a carrier. What about the babies? AA, normal. AA, carrier. AA, normal. AA, carrier. That means 50% chance baby will be completely normal. 50% chance baby will be a carrier. It will be a carrier, 50%. So these percentages are also important. So out of given options, best thing is paternal hemoglobin level. 32. A 24-year-old woman presented at 10 weeks of POA with intractable vomiting. She had features of dehydration. Her blood pressure is low. Pulse rate is high. What is the first line in the management of this patient? Is she stable, unstable? She is unstable because blood pressure is low, pulse rate is high. So again, your airway breathing circulation business comes. So intravenous normal saline bolus, intravenous ranitidine, intravenous ondansetron, that is enzymatic, intravenous furosemide do not marry patient because she is anyway free depleted. You don't give rapid intravenous bolus of glucose. No point of giving glucose. You don't give glucose in hyperemesis. What is the best thing? Intravenous normal saline bolus. Next step would be that. Then after that, you have to give IV ondansetron. First thing is you have to correct this intravascular volume. Okay. Next question. Why don't you give dextrose initially in hyperemesis patients? It can precipitate Wernicke's encephalopathy. Do I need a break? No. I hope no. Break ගන්න තරම් වෙලාවක් නැහැ දැන්. ඔළුව ගිනි අරන් තියෙන්නේ. අල්ලලා බලන්න ගිනි අරන්ද කියලා? ආ නෑ, එම් පාටක් පේන්නේ නැහැ. Okay. Question number 33. 30-year-old primipara at 31 weeks of gestation found to have abdominal circumference below 10 centile. The dates were confirmed at 11 weeks. The pregnancy is otherwise normal. What is the best indicator to elevate fetal well-being? So, this is the growth chart. You have the 90th centile here and you have the 10th centile here. So at 31 weeks, baby's weight is below the 10th centile. So what is your answer? What is this condition? What is this condition? Baby's weight is below the 10th centile at 31 weeks. What is your answer? What is the condition of the baby? This is small for gestational age. Yes, very good, Mithila. Right? This is not IUGR. You can't say IUGR. This is small for gestational age. What are the three possibilities? Wrong dates, IUGR, constitutionally small baby. Constitutionally small baby. Those are the differential diagnosis. So they said that Dates confirmed, no problem about that. She's sure she's 31 weeks. So you are remaining with two answers, either constitutional small or IUGR. We'll see. What is the best indicator to elevate fetal well-being? Amniotic fluid index. In IUGR, amniotic fluid will be less. In constitutional small babies, amniotic fluid will be normal. So that is also important. Monitoring using fetal kick count chart. Apo kick count chart is very subjective thing. It's not an objective thing. It's not reliable. Middle cerebral artery Doppler studies. MCA Doppler. I'll come to that later. Umbilical artery Doppler. Uterine artery Doppler. Will you do uterine artery Doppler? Can you remember early in this class, I told you uterine artery Doppler is done in early pregnancy to detect high-risk people. Umbilical artery Doppler is done to diagnose IUGR. Middle cerebral artery Doppler is done to decide the time of delivery. Right? Remember, uterine artery Doppler is done in early pregnancy to predict IUGR. Umbilical artery Doppler is done to diagnose or confirm IUGR. Middle cerebral artery Doppler is done to detect the time of delivery, whether to deliver today, tomorrow, or 1 week time, something like that. So what is the best thing? Still, we don't know whether this is IUGR or constitutional small baby. So you have to confirm with the Doppler. When you take amniotic fluid and the Doppler, what is more reliable? Doppler. Umbilical artery Doppler. Question number 34. Usually my teaching pattern is a little bit slower than this, and I used to explain everything in and out the question. But today, because of the limited time factor and you have your exam is near future, so I'm going a little faster. But if you can't understand anything, please let me know later. Right. Question number 34. 25 years old teacher worried that several students in a class had developed rubella. The POA is 10 weeks. And she cannot remember whether she had vaccinated against rubella. What is the best step in management? So this particular teacher is not sure whether she had the rubella vaccination or not. So several students, that means she has a close contact with rubella at 10 weeks. Is she having a risk of rubella? What can rubella do to the baby? Fetal rubella syndrome. Can you remember breast triad? In addition, you can get microcephaly, cataract, all these abnormalities. So she is having a risk. What is the next best step of management? Administration of immunoglobulins to the mother. Is there a treatment option like that for rubella? No. In which condition you can give immunoglobulin? Varicella, chickenpox, as a preventive measure, not for rubella. Perform ultrasound scan in 4 weeks' time. She is now 10 weeks. At 14 weeks, can you diagnose all these problems? Chorionic villus sampling for rubella DNA. Very invasive. Check the mother's serum rubella specific IgG. Because mother is not sure whether she is immunized for rubella or not. How you can check the immunity? By checking antibodies. What antibody? IgM or IgG? IgM means infection, recent infection. IgG means immunity. So what we have to do? Check the mother's serum rubella for specific IgG. Response D. Remember, there are two main antibodies after infection, IgG and IgM. IgG means you are immune. IgM means you have the recent infection. 35. A 35 years old second para presented to the antenatal clinic at 16 weeks. She has a history of preterm labor in her previous pregnancy at 26 weeks. Preterm labor. This time, cervical length is 2 centimeters on ultrasound scan. What is the best management option to prevent preterm labor in this pregnancy? So this is the second pregnancy. First pregnancy, she had a preterm labor at 26 weeks, early pregnancy. Now she is pregnant and her cervical length is just 2 centimeters. What is the normal cervical length? What is the normal cervical length? 4 centimeters. She is just having half of that. Because her cervix is shortened now. There's a strong history of preterm labor last time. So what you can do now? To prevent preterm labor this time, what you can do? You can put a cerclage. Okay, because there's a clear evidence she had a previous preterm labor and her cervix is shortened. So best option would be go for a cerclage. Answer is first one. 36. A mother admitted her 5-year-old daughter with a complaint of sexual abuse 2 hours ago. Young chap, she's just 5 years. Mother brought the child saying that she had abuse 2 hours ago. The initial general examination showed no trauma and the general appearance seems satisfactory. As the HO, what is your next step would be? You are the HO, 5 years old girl, history of sexual assault 2 hours ago, externally looks fine. Advise the mother not to wash the child's perineal area until the JMO sees the patient. Because if you want to take a swab or something, if you wash the area, then those the evidences will be erasing. Reassure the mother. As a HO, can you reassure the mother? I'm not buying any pharmaceutical. Erpm internship. Can you all do that? You are not mature enough and you are not legally bound to reassure this mother. Inform the police. They're asking the next step. Inform the police. Normally, when something like this happens, you have to first inform your consultant. As a house officer, that's your first thing, right? Even before you examine the patient, you have to inform the consultant and get his opinion. If the consultant says straight away, okay, refer this patient to a JMO, then you have to refer this patient to a JMO. Because JMO will assess the baby, do the examination and everything. Take the legal actions. Investigate for STI. Again, that's you can't do alone. Take a swab for semen. No, that is also not, you are not confident. Because sometimes you might have to take a swab from the vagina inside. That you can't do it alone. So the answer is either inform police or the first one. I think as a HO, what you can do next step, as a next step, ask the mother to keep the baby in the ward and not to waste the perineal area till the JMO comes. Then you inform your senior, your consultant, and get down a JMO soon as possible and ask him to complete the rest. Question number 37. A 17-year-old girl was brought by her mother saying that she has encountered in a sexual activity with her boyfriend without her parents' acknowledgement. Right? The parents brought the child. This was not happened in Kalutara, right? The parents brought the child saying that she had sexual intercourse with her boyfriend. She wants to know whether her virginity is intact. Mother is very keen about the virgin. These days, people are just kick off this virginity. Who cares? Because you know, if you can spend 25,000 or 30,000, you can create a new hymen. This is just a simple procedure. And so girls, don't worry. Anyone, girls, if somebody knows to you, ask about these things. These are very minor things. So nobody cares about the virginity, but this particular mother is very keen. She wants to know whether she is still a virgin or not. What is your management as a house officer in this scenario? Ask her to lodge a complaint with the police. In this case, it's not your job. Examine for assaults. Examine for sexual assault that you are not confident enough. Obtain a history in the absence of mother. You can put interest otherwise I will. No big issue. Prescribe emergency contraception. Yes, that is a good option. You may be having Postino in your pocket. Give her. Right? Something like that. You can use emergency contraception before something else is done to prevent pregnancy. Take consent from the girl for examination. Examination for this particular thing, you are not confident. You are not confident to go to the court and give the evidence. Okay. So best thing is you have to inform your consultant, and best thing is use some emergency contraceptive to prevent a pregnancy. Something like that. Just for gossip, that's good. Good to know, but as an answer, I don't think. Question number 38. In 2020, the perinatal mortality rate in Sri Lanka was 11. What is the meaning of this statement? Perinatal mortality rate. What is perinatal mortality rate? Does anyone know? You have to know. How will you calculate the perinatal mortality rate? What are perinatal deaths? Perinatal deaths are all IUDs, intrauterine deaths, plus early neonatal deaths. Early neonatal deaths means death of a baby within first week of their life, within first week. So you calculate, you collect everything together and divided by perinatal death rate. Total live births in 2000. That means when 1,000 live babies are born, how many of them are going to die? Something like that. Perinatal mortality rate. So Sri Lanka, it was 11 in 2020. So what does that mean? 11 early neonatal deaths and stillbirths per 1,000 total births. 11 total neonatal deaths and stillbirths per 100 live births. This 100 business is out. So B and C is totally out. D, 11 total neonatal deaths. These are not neonatal deaths, early neonatal deaths. So that is D also wrong. E, 11 early neonatal deaths and stillbirth per 1,000 live births. What is the answer? That is the answer. Response. When you calculate the maternal mortality rate, per 100,000, not 1,000, per 100,000, that is total births, not live births, but total births. Those differences you should know. Question number 39. A 26-year-old woman presented to the sub-fertility clinic with a history of absent periods for 1 year duration with galactorrhea. What is galactorrhea? Milk secretion in non-pregnant state. That is called galactorrhea. Diarrhea ke malli wage. Galactorrhea. Further investigation revealed a pituitary microadenoma. Microadenoma in your medicine and surgery knowledge, what is the size? Less than 1 centimeter. Pituitary tumor which produces prolactin. Pituitary microadenoma less than 1 centimeter. So she's fertile daru and she's having galactorrhea and absence of menstruation. Further investigation revealed a pituitary microadenoma. Her partner's SFA is normal. Husband seems to be okay, normal. What is the best treatment to improve her fertility? She's having hyperprolactinemia due to microadenoma. What is the best treatment? Laparoscopy and ovarian relief. That is for what? That is polycystic ovarian syndrome. But nowadays, this is out of fashion. Ovulation induction with clomiphene citrate. What is the reason she is not ovulating? Her prolactin levels are high. So you have to bring down the prolactin to normal levels for her to menstruate. Ovulation induction with human menopausal control. Whatever it is, first of all, you have to bring down the prolactin levels. Pituitary surgery. Treatment with cabergoline. Yes. For pituitary microadenomas, Darwane, less than 1 centimeter size, usually you can treat with medicine, drug. Drug of choice will be cabergoline. Where else you give cabergoline? For the milk suppression, same thing, because they suppress the prolactin levels. Any other drug? Bromocriptine. Bromocriptine. Same action. Those are dopamine agonists. Dopamine agonists. If it is a macroadenoma, usually they need surgery. If it is a microadenoma, usually you can treat with bromocriptine or cabergoline. Question number 14. An 8-year-old elderly female complains of urge urinary incontinence. BMI is high and she is well controlled with diabetes mellitus. Diabetic patient. What is the best treatment option for her? Elderly lady, 80 years means elderly, having urge incontinence. She's a diabetic patient but under control. High BMI. Maybe not connected something like that. Urge incontinence. What is the best treatment option for her? Tolterodine. Can you give tolterodine for urge incontinence? Yes. Oxybutynin. Same kind of drug. You can use oxybutynin and tolterodine. What is the difference between tolterodine and oxybutynin? Oxybutynin causes a lot of parasympathetic side effects. Dry mouth, dry eyes, constipation, imbalance, hypotension. All these things can happen with bromocriptine. For an elderly lady, oxybutynin is not a good option. It's not a good option for an elderly lady. Advise her to wear adult diapers. I mean, it's not a good option. Birch pulp suspension. Surgery you do in stress incontinence, not in urge incontinence. Remember. Indwelling catheter. Again, this is for continuous incontinence, fistula and all, but otherwise you don't recommend indwelling catheters for elderly people because it can cause sepsis infections and patient can be set the pouch if there is an infection. Shall we take a deep breath? Forget about everything about your boyfriend for the time being. Think something interesting like Jnana Katha, Anamalu, like that. Something interesting, Kalbanis. So are you all ready for your exam now? Whether you like it or not, you have to get ready now, right? So people who have worked from beginning, I always used to tell you all, so start working from beginning. Now that time is past. Now those who have done work from beginning, you have to just revise your knowledge these days. Just, you know, you have to just go through your notes. Computer per learn it. You have to just go through the highlighted parts. But people haven't worked so far, then it's going to be really difficult. But at least go through your papers and try to revise something. Remember, when it comes to MCQs, try to answer 3 for a sure, not to guess 4th and the 5th. Right. Question number 41. Question number 41. A 58 years old female, 3 years after menopause, presented with vaginal bleeding. Okay. 58 years old female, 3 years after menopause, presented with vaginal bleeding. She also has dyspareunia and postcoital bleeding. Dyspareunia and postcoital bleeding. Because even though the Archie is menopause, he is not andropause. He is still an active guy. So she is having dyspareunia and all these symptoms. Postmenopausal bleeding. Speculum examination revealed a healthy cervix with thin, shiny vaginal epithelium, and rest of the clinical examination is normal. Transvaginal scan showed a small uterus with endometrial thickness of 3 millimeters. What is the most appropriate treatment for her? Okay, Daru, this is postmenopausal bleeding. What are the differential diagnoses for postmenopausal bleeding? First thing, if a lady comes with postmenopausal bleeding, what is the first thing that you have to think of? CA endometrium. Second differential diagnosis, CA cervix. What next? Cervical polyps, endometrial polyps, and benign conditions. What last? Atrophic vaginitis. But for you all to come to that diagnosis, you need to exclude other things. So when a patient comes with postmenopausal bleeding, what's your first thing? Put a speculum and visualize the cervix. What is your next thing? Do ultrasound scan, transvaginal ultrasound scan, and measure endometrial thickness, ET. If ET is more than 4 millimeters, go for a biopsy, either PIPL, DNC, or ideally hysteroscopy. If the endometrial thickness is less than 3 millimeters or less than 4 millimeters, what you have to do? Reassure. You don't have to do anything. If there is atrophic vaginitis, you can treat with estrogen. But you don't have time to write down things now, right? You would have done that before that. All right. So what is your diagnosis in this condition, Daru? She's having postmenopausal bleeding. What is more likely? Is it endometrial cancer? Why not ESM? Because the thickness is less than 4 millimeters, Daru. Is it cervical cancer? Sadish. It is cervical cancer? Unlikely. Why you say unlikely? Speculum examination, normal cervix. Is it polyps or anything? No. Scan doesn't show anything else. So what is your diagnosis? Once you exclude everything, your diagnosis is atrophic vaginitis. Most appropriate treatment for her, diagnostic hysteroscopy. Do you need a hysteroscopy? No. If that is more than 4 millimeters, you have to go for hysteroscopy. Dilatation and curettage? No. Pipel biopsy? No. Total abdominal hysterectomy? No. Estrogen cream for local application? Yes. Actually, estrogen cream, then she won't come back and she will be happy. She also will be happy. You won't see them again. let them live happily if you give just simple estrogen cream. Is he happy when? I don't know, but he's happy. Question number 42. Then you can kallalle, bullalle, lallalle wage dinne. Are you all tired now? Come on, tired now. We'll do the next. 42. 30-year-old woman presented with regular heavy menstrual bleeding for 6 months duration. Regular cycles are regular, but each episode is heavy. What is the diagnosis? Give me a name. What is the name, single name you can give? Regular heavy bleeding for 6 months.
Menorrhagia.
Menorrhagia, exactly. Very good. It's called menorrhagia. So she's having menorrhagia for 6 months. She has regular cycles and no intermenstrual bleeding. She's hoping to conceive soon. Ranil Janadipati coming yanna kalimma pregnant වෙන්න බලාගෙන coming soon. She's hoping to conceive soon. Ultrasound revealed a 5 centimeter posterior wall fibroid slightly bulging into the uterine cavity. Okay, she is having a 5 centimeter size posterior wall fibroid, slightly bulging, compressing the endometrial cavity. Sorry. Yes. Okay. What is the most appropriate management option for her? What are the two problems of this patient? Is this the fibroid is the reason for her bleeding? Can you blame to this fibroid causing menorrhagia? Yes or no? Fibroid එකට ඔයගොල්ලන් බයිනවද නැද්ද? මේ මගුලේ fibroid එක කියලා අපි exam එකක් කියලා දැම්මා. Something like that. Will you blame the fibroid for causing menorrhagia? Yes. Because this is kind of intramural fibroid distorting the endometrial cavity. Yes, it can cause menorrhagia. Can fibroids cause irregular bleeding? No, no, no. If the fibroid causing bleeding, that it should be menorrhagia, regular heavy bleeding. Yes, this may be the culprit. So if you consider menorrhagia part only, bleeding part only, what is the best management? Fertility again, her biggest problem is, suppose her biggest problem is bleeding, what will you consider? Menorrhagia. Yes.
Myomectomy?
In that case, yes, exactly. In that case, best option would have been go and remove this fibroid. Problem will be sorted out. But now, she's not a patient who is having 2-3 kids. She's hoping to have her first baby. Trying to, she's looking forward to become pregnant. So if you do a surgery on this patient now at a glance, right? As a first line, if you do a surgery on her, while you are trying to remove this fibroid, you may damage the endometrial cavity because it's so close. And after myomectomy, it can cause a lot of adhesions. So it might later block her tubes. So what will you do as the first line for this patient? What is more important? Important is for her to have a baby first. Meantime, you have to suppress her bleeding also. So we will see the options. Myomectomy. If you do the myomectomy, those problems can come. So you have to put that thing as a latter option. Mefenamic and tranexamic acid. Yes, it's a good option for menorrhagia because cycles are regular. You have to give mefenamic and tranexamic only during menstruation. 3-4 days, then the bleeding will be stopped. GnRH analogs. For a young patient, you don't give GnRH analogs. It suppresses your menstrual cycle. Ulipristal acetate, again, a pharmacological agent, ulipristal, but we don't know the safety as far as the pregnancy is concerned. Otherwise, it's an option we will see. Uterine artery embolization. Uterine artery embolization also can be done, but the problem is the fertility. We don't know what's going to happen to the fertility. So what is the best option for her? Mefenamic and tranexamic. Give mefenamic and tranexamic acid, see the response. If she's responding well, ask her to conceive. Once the pregnancy is completed, then later on, if you want, you can remove this pill. Suppose now you give mefenamic and tranexamic acid and ask her to become pregnant. Then other pregnant, something like that. You give advice to the patient and send her patient. You take these 2 tablets, Sadish. Okay, you give these 2 tablets and ask her to conceive again, complete her family. Now she is trying and trying and trying. After 6 months, she is coming back and tell, Doctor, you haven't done anything for my medical condition. Now what you can do? Can this intramural fibroid distorting the cavity, can it disturb or can it block the pregnancy as well? Yes, there is a possibility. In that case, you can go and remove the fibroid. Because fibroid may be the reason for subfertility. Remember, because even though this fibroid is there, sometimes she can conceive. That's why we give her time and see. But if she can't conceive also, and if she's in menorrhagia also, then best option is this. Vilangada, Peria. Any problem? See, fibroids, unless they are symptomatic, you don't have to treat them. Especially when you're offering surgical option for a subfertile patient, you have to see whether if the fibroid is really responsible for subfertility. Now, if you have fibroids like this, like there, right, you don't have to remove them. Battery running low. Just give me 1 second. Okay, right, clear. Question number 43. The 43-year-old mother of 2 children came to the subfertility clinic seeking advice to getting pregnant again. She is 43 years. Lamai dennekut innawa. She may be a psychiatric patient. අවුරුදු 43 ද නැත්නම් ආයෙ pregnant වෙන්න try කරනවද? ඉන්නේ උන් දෙන්න හදාගන්නේ බොහොම අමාරුයි. Right? Getting pregnant, she is seeking medical advice. She had undergo LRT after the second pregnancy. After second pregnancy, she had LRT also get done. වැහිලා තිබිච්ච ෆැක්ටරි එක කාලෙකින් ඕපන් කරන්න හදනවා. Now she has mild endometriosis. කොහොමද තියෙනවා මෙයාට? What is the best option? IUI, decline further treatment, IVF, ovulation induction is surrogacy, reversal of LRT. Remember, even though you reverse the LRT, the success is very low. Then she is already having 2 kids. Are you recommend for anyone to conceive at the age of 40 or after 40 years? No. She's having high risk of Down syndrome and all the syndromic babies, and she's having a risk of preeclampsia, diabetes, and all the complications. So you have to decline further treatment. You have to counsel the mother. Question number 44. 28-year-old lady married for 1 year, presented to a subfertility clinic. She has regular cycles and no comorbidities. They are engaged in regular sexual intercourse. What do you mean by regular intercourse? BD, TDS. 6 hours. What is regular intercourse? 2 to 3 times per week. Sometimes you get once per month. Most of the patients, when you ask, once per month or twice per, once in 2 months time, something like that. But for a pregnancy purpose, you need to have 2 to 3 times per week. The husband has frequent impotence, but his SFA is normal. Count is normal, but he is having impotence, erectile dysfunction. What is the best management option for them? The girl seems to be okay, regular cycles, no comorbidities, but the husband is having erectile dysfunction. But SFA is normal. Ovulation with induction with clomiphene citrate. Refer the partner to a genitourinary surgeon. Ovulation induction followed by IUI. IUI only. Treatment of the partner with testosterone. What you have to do if there's a person with impotence? Impotence may be psychological. Okay. Impotence may be a psychological thing. So you can refer to a psychiatrist. If you obviously think that there is a problem with his organs, any organic problem, you can refer to a genitourinary surgeon, but they also can't do much about it. So the problem here is he can produce sperms, but he can't do the rest of the job. That means he can't go and deposit within the vagina. So what you can do? You can assess him to do the job. That means you can collect the sperm sample and you can go and deposit within the vagina. What is that called? IUI. That is called IUI. So here, the problem is with the male partner. So he can't deposit sperms within the vagina. So you can do that by doing IUI. Do you really want to do ovulation induction? Because if there is no problem with the female partner, if she's ovulating, you don't have to do ovulation induction. Because it says she's otherwise normal, young patient, no comorbidities, regular cycles. So in that case, female partner seems to be okay. So what you have to do is do IUI only. If there's a problem with the female partner ovulation problem, then you can do the ovulation induction and IUI. But in this case, you need only IUI. 27 years old university student come to you for contraceptive advice following unprotected sexual intercourse with a boyfriend 72 hours back. Her last regular menstrual period was 8 days ago. That means she's in her fertile period now. What is the best method for her that would prevent contraception? They had sexual intercourse about 3 days ago. So, single dose of DMPA, no, doesn't work. DMPA is not an emergency contraceptive. Copper IUCD. Is it effective? Yes, copper IUCD is effective up to 7 days. Up to 7 days. Manage conservatively as she is having low risk of getting pregnant. So you can't say like that. Start a new pack of combined oral contraceptive pill to be used regularly. Give 2 tablets of levonorgestrel and take after. What is levonorgestrel? That is Postino. Postino is effective up to 3 days. Now she had sexual intercourse 72 hours ago. So best option would be copper IUC. If she had sexual intercourse yesterday, what is best? Copper IUCD or Postino? Which one is more effective? Again, copper IUCD is more effective. So be careful, girls and boys. Postino is effective up to about 85%. There's a 15% chance still you can conceive. You do your exam first. Question number 46. A 34-year-old sexually active female presented to the gynae clinic with the malodorous, frothy, greenish, yellow vaginal discharge. Frothy, greenish discharge. Characteristic of what? Trichomonas. Greenish, frothy discharge. Greenish and frothy discharge is more characteristic of trichomoniasis. What is the treatment? What is the treatment for trichomoniasis?
Metronidazole.
Metronidazole, very good. What is the treatment for bacterial vaginosis then?
Metronidazole plus clindamycin.
Yes, even metronidazole alone also enough, but you can add clindamycin. But main treatment is metronidazole. Trichomoniasis causes characteristic features of cervix. What is that called?
Strawberry cervix.
Strawberry cervix. Who's this brilliant girl? I can't see her face. What's her name, Daru?
Manuri.
Soft voice. I love that voice, but I can't identify who is that. Anyway, I think it seems that you are studying. Question number 47. A 16-year-old girl presented to the gynae clinic with a 6-month history of irregular menstrual bleeding and dysmenorrhea severely affecting her quality of life. This is irregular bleeding, 6 months, and abdominal pain. Trans-abdominal ultrasound scan and other first-line investigations were performed were normal. Scan normal. What is the most appropriate treatment for this patient? Combined oral contraceptive pill, cyclical progesterone, medroxyacid, that's DMPA, mefenamic acid, canaxamic acid. This is irregular bleeding for 6 months. What will you offer? And she is having dysmenorrhea, irregular bleeding. She's young, 16 years, maybe unmarried. But unmarried. What is the best treatment? If it is irregular bleeding, Targo, and severe dysmenorrhea, disturbing her quality of life, best thing is go for OCP. OCP. It will regularize the cycles, it will reduce the bleeding, and it will reduce the pain and all the discomfort. Mefenamic and tranexamic acid will not work for irregular bleeding. It's just temporary. For menorrhagia, yes, because menorrhagia only short period, but heavy bleeding. So by giving mefenamic and tranexamic, you can control it. But this thing, not. 48. A 35-year-old woman presented with heavy menstrual bleeding for past 6 months with 28 days regular cycles. So 35 years old, heavy bleeding, heavy regular bleeding, again menorrhagia. Clinical examination and transvaginal scan findings were normal. She had a hemoglobin level of 8.5. She also suffers from severe migraine with aura. How the? Not Lara, Lara Gimalli, aura. She is having migraine and aura. Brilliant students ට මතක් වෙනවා what? මට පින සමහර students ලා දිලිසෙනවා මෙතන brilliant students. When you say aura, what comes to your mind suddenly? You can't give OCP.
OCP.
Yes, yes. OCP is contraindicated when there is migraine with aura. Absolutely contraindicated. Okay, right. So she is having menorrhagia, hemoglobin level is slightly low, and she is having migraine with aura. What is the most appropriate management option? Cyclical treatment with combined oral contraceptive is out because she's having migraine. Dilatation and curettage. Why you want to do dilatation and curettage? To get a biopsy from the endometrium. Why you want to get a biopsy? To exclude a malignancy. In a patient with regular heavy bleeding, that is menorrhagia, do you suspect malignancies? In other words, what are the differential diagnoses for menorrhagia? Tell me. What are the differential diagnoses for menorrhagia? Submucosal or intramural fibroids. Remember, not all fibroids. Endometriosis, adenomyosis, PID. Okay, endometriosis, adenomyosis, PID. Then DUB. What is DUB? Dysfunctional uterine bleeding. So these are the common differential diagnoses for menorrhagia, regular heavy bleeding. Remember, under this, none of the malignancies or non-malignant conditions will not come. Pre-malignant conditions will not come under this. So menorrhagia patients, remember, you don't have to do a DX or a biopsy. So this patient is having menorrhagia, so you don't have to do a DNC. Northeastern for 21 days. When you give northeastern, usually northeastern is given this kind of patient for irregular bleeding. To stop the current bleeding episode, you have to give northeastern for at least 3 weeks. So this is correct. Oral iron supplementation. Yes, you have to give oral iron because she is hemoglobin low. But iron will not stop the bleeding. Tranexamic acid for 5 days with the start of menstruation. No. Sorry, I made a mistake. So this is menorrhagia. Remember, sorry, I made a mistake. Forget everything. Take a good breath. But again, come on, okay. When there is menorrhagia means regular heavy bleeding. What are the management options? You can use tranexamic and mifenomic acid. You can with the bleeding episode. You can give OCP, right? Those are, and you can do other treatment options also. Those are 2 common management options. When there are irregular bleedings, you control that. You have to give northeastern for 21 days. But in menorrhagia, you don't give northeastern because menorrhagia means regular bleeding. In that case, you are not giving northeastern. Mifenomic and tranexamic acid you can give, but the northeastern is given for irregular bleeding. But the question says this is regular bleeding. So she cannot be given OCP because of the aura and the migraine. Dilatation and curettage is not necessary because this is not a malignancy. Northeastern is not given because this is regular bleeding. Oral iron supplementation you have to give. Tranexamic acid for 5 days with the start of menstruation. Yes, tranexamic acid you can combine with if you want mifenomic also. So menorrhagia, one of the first line image management is mifenomic, tranexamic, and OCP. Irregular bleeding, northeastern, and you can give OCP as well. This patient you can't give OCP because of the migraine. Question number 49. A 55-year-old woman after 3 years of menopause presented with severe vasomotor symptoms, menopausal symptoms. What is the most effective drug in her treatment? 55 years old, menopause for 3 years, vasomotor symptoms. What is the most effective drug in her treatment? Clonidine. I told you, clonidine can be given as a supplement to HRT. It's true. Conjugated estrogen. True or false? Why such it is false? Type why it is false? Yes.
Because it is having an increased risk for hypoplasia.
Yes, sir.
Endometrium.
Because the question haven't given any information whether she had hysterectomy or not. So you had to assume that she is having her uterus. So in that case, estrogen only preparations you can't give. Combined oral contraceptive pills. Combined pills are not considered to be an option for HRT. It's different. Fluoxetine. Yes, antidepressant drug you can give. Venlafaxine. Venlafaxine also antidepressant, so you can be given in menopausal patients. So out of all, what is the most effective drug? Clonidine would be more effective. Because other drugs, they may be having their other side effects also. The last one. A ward staff has informed you that a patient who had undergone a total abdominal hysterectomy 3 hours ago has passed only 30 ml of urine. The body weight is 50 kilograms. So if the body weight is 50 kilograms for an hour, how much of urine output should be there? How much of urine output should be there if the body weight is 50? .5 ml per kg. Yes, that means there should be at least 25 milliliters per hour. So after 3 hours, 75 ml should be there at least urine output. But she's having only 30. Blood pressure is stable. Pulse rate is also good, 82. What is your next immediate step of management? I'll take 2 minutes to explain this. Okay. So regarding urine output, have you all heard of this concept called pre-renal, renal, post-renal? That means that when the urine output is less, you have to think in this way, whether this is a pre-renal cause or renal cause or post-renal cause. What do you mean by pre-renal? Pre-renal means for the kidney to produce urine, there should be blood supply. When the blood supply is shut down to the kidneys, what will happen to the urine production? Will be less. What will happen to the urine output? Will be less. So what are the pre-renal causes? Dehydration. Common. Bleeding, especially after a surgery, when there is internal bleeding, right? When there's bleeding into the peritoneal cavity, patient will be in a shock state, so the blood supply to the kidney will be cut down. So bleeding, very important, especially after surgery. So those are the two things that you have to think of, pre-renal causes. What are the renal causes? Renal failure, maybe acute renal failure. You would have given some toxic antibiotic or toxic painkillers like NSAIDs. Kidney can go into sudden failure, acute renal failure. Even though the blood is coming, kidney cannot produce urine. That is renal causes. Those are not common after a surgery. This is the most dangerous one, pre-renal. Renal. What is post-renal? The kidney may be getting blood, kidney is normal and producing adequate urine. However, this outflow tract is blocked. Maybe commonly because of the catheter, because you all know that after a major surgery, patients are on a catheter. When the catheter is blocked, even though the patient produces urine, there is no output. This is the commonest reason. This is the most dangerous reason, bleeding. So, if a patient's urine output is, when you are doing your internship, when the nurse calls it structure, අර අපි TH කරපු patient ගේ urine නෑනේ. Then what will you do? You immediately attend to this patient. What is the most dangerous thing? Is it the catheter block? That is not the dangerous thing. What is the dangerous thing? Patient may be having bleeding internally. TH may be bleeding inside. That may be the reason. So, if there is bleeding, what will happen to your pulse rate? Will go up, low volume pulse, and patient blood pressure will be low. So, when you check those, if the blood pressure is low, pulse rate is high, you know, either dehydration or bleeding. So, you have what you have to do. Give immediate fluids and hydrate the patient, and if there's bleeding, give blood and immediately go for a exploration laparotomy. Okay, that is the first thing that you have to assess. What is the commonest thing? Renal causes are not common though. What is the commonest thing? Maybe catheter block. When the catheter is blocked, what will happen to the bladder? Bladder will be distended with urine. So when you clinically palpate the abdomen, bladder may be distended. Then you know catheter is blocked. So what you can do? You can flush the catheter first. If it is not resolving, you can change the catheter completely. You change the catheter, urine will be coming like a tsunami. Then you are more happy. Seeing urine, if you can happy, that you are only a doctor. No one else will be happy by looking at urine. But doctors, as doctors, we are happy to see urine. Yeah, hello. What to do? Then if you think there is no catheter block, there is no pre-renal causes, then you can do renal creatinine and in serum electrolytes and see whether any problem with the kidney. Okay. In that case, if there are renal causes, you can use diuretics to see the response, like furosemide. Otherwise, any diuretic for this patient without properly assessing why. If the patient is already having pre-renal, if you give diuretics, patient will definitely go into shock and set the body. Your boss will kill you. Last again, kill but for a boy, you have to be very careful. Okay. Pulse rate is 80. So this patient, blood pressure is normal, pulse rate is normal. So are there pre-renal causes? Highly unlikely. You don't have to think about it. What is the next thing? Maybe post-renal. What is the next immediate step of management? Arrange ultrasound scan of the abdomen. Check whether the catheter is blocked. Yes. Intravenous furosemide. Remember, intravenous furosemide we don't give. Take blood for serum creatinine. That is later if you suspect renal causes. Transfuse blood. That is for pre-renal. So what is the best answer? Would be check catheter and flush catheter. Not responding, change the catheter.